I really believe that we are stewards of good care for our patients, and kyphoplasty is one of these things that's been through different phases just during my 10 years in practice. And I've been on the one end of the extreme of doing a kyphoplasty on everybody that came in, to now being a little bit more selective. There's a lot of information out of there. There's a ridiculous amount of information out of there, and I think you have to try to do your best to filter through that. So I do some work with St. Jude, involved in a couple studies. This is somebody who definitely has been to have kyphoplasties and vertebroplasties done. It's a pretty fascinating picture. I'm going to talk just a little bit of background information, not a lot of slides. I've got a little timeline, and then we're going to talk about what's new. There's new stuff, but it's not necessarily that new, and we're not going to talk about any major studies in it, but I'm going to try to give you, kind of like Miles did, a little smorgasbord of what's out there, of what some of these different tools are, a little literature summary, and then probably something that hopefully will be more useful to you, something I know would have been useful to me when I was in your shoes, which is a sample algorithm. What do I do to treat patients? And so the first percutaneous vertebroplasty was done at the C2 in France back in 1984. It was actually done transorally, something I'm not sure that I would ever want to entertain. I have done some cervicals for cancer patients, but they've been just not that high. First publications came out about 5 years later. Then we had the balloon kyphoplasties at the beginning of the century. We had sort of this technology burst that went along with sort of payers, and if you look at some of the background, the reimbursements on these, we had this abundance of people coming into the marketplace to provide different tools, different techniques. The efficacy of vertebral augmentation was challenged in 2009. I'll show you again where it was kind of challenged in the Cochrane review in 2015. We have got a standards committee of multiple societies that came together and put a statement out in 2014 supporting kyphoplasty and vertebroplasty. Interestingly, this is a fracture patient whom I saw maybe a month or two ago. I shared this slide with Dr. Justice, and I just reached through my phone to try to add it. This was a patient whom the radiologist read the report and said, this patient would be a great candidate for kyphoplasty. And so then the hospital they consulted me, and I came and I looked at these, and I was looking at the pictures thinking, wow, this doesn't really look very good. He's transected that whole level, and then there's a vertebral plana below that, and there's one above it, and I went up and I talked to the guy and started evaluating him, which is key because if you just look at the films, you miss the big picture. Guy, I mean, he fell, he had an injury, he hurt his low back. His thoracic spine didn't hurt him at all. We treated him for a day with some Dilaudid IV or something, put him on a little bit of Percocet, saw him back 2 weeks later. He'd already tapered off of all that medicine and was better. Never had any problems in this area. So deceptively, all those things, sometimes you have to take it all in, examine all. Here's the position statement that came out in 2014. This goes against, this was sort of a rebuttal to a New England Journal article in 2009 saying they did one of these fancy randomized controlled double-blinded trials that showed that there was no difference between placebo or facet injections potentially and doing a vertebroplasty. Well, I think the key take-home points are that not everybody that has a fracture needs it fixed. And before all these were being done, people were getting fractures, and people will continue to get fractures. And as people get older and we have more osteoporosis, and people will continue to have fractures. And the natural history of these fractures are to heal. So I think, and I'll go into my algorithm of treatment, But I think you have to look at that as the bigger picture, that it's likely in almost everybody that they're going to get better. And it's our job to selectively identify those patients who might not get better, and then what can we do to help them. This was the Cochrane database review. It just kind of came out the year after that, saying, once again, we don't think that they do anything, so you shouldn't do them in anybody. And I think the answer is somewhere in between. When we look at kyphoplasty, vertebroplasty, vertebral fractures, I think it's important that we look at this as an event in a spectrum of a problem. And the problem sometimes is cancer, but most of the times it's osteoporosis. These injuries, vertebral compression fractures, are 90+% related to atraumatic injury, somebody that falls from a standing height. They didn't do very much of anything. They reached above to get to the cupboard above them and had this acute onset of pain. Treating the osteoporosis is probably pretty important. This was an interesting article that is some of the new stuff that I found from this year. You know, we don't want to be the guys. I like the IR pain. You know, we're kind of the little guys down there. But I don't do this, and I don't want you guys to do this. Think about their osteoporosis. Get on the phone, send a letter. You know, I don't want to be responsible for necessarily doing the treatment for the osteoporosis, but I will order a DEXA scan. I will initiate making sure that patient has care, because even in the big metropolitan areas, osteoporosis is still, I think, under-recognized and under-treated. There we go. So there is an exorbitant amount of information out there, and it is not unlike, you know, a lot of other things that we have in our practice setting. A little bit different than when we look at facial pain and we look at facial pain and stimulators. There's not a lot of literature out there. Some of these, you know, some of this work that Dr. Rax does with the scarring triangle, we're getting into that information, but it's not like, you know, looking on PubMed and seeing 100, 200 different articles in 1 year. So these were just some time frames that I looked at, and those are some of the summaries that I came away with on reviewing a lot of those pieces of information. If you want any of those articles, if I have the full articles, I can send them to you. If it's an abstract, I can send it to you. I have a slew of this stuff in preparation. That's the information. The information is that there seems to always be an article that is for something and always something against it. You can almost, it's like statistics. You can find and make it say whatever you want. The new stuff, I think the stuff to take home is what's out there now. We have different uses, we have different tools, we have different materials, and then there are some technical considerations that I thought were kind of neat. I better spark it up, or Dr. Rax is going to lose interest. He's had a long night. So, different uses of the same idea. We've got the tumor ablation before augmentation, and that's been done back as early as 2004, but it's really seen a resurgence. The NCCN guidelines, which is the guidelines that give our oncologists, that's sort of the pathway that they follow. If it's not in their NCCN guidelines, they don't do it. Last year in February, 2015 guidelines came out, and they did put in their RF ablation and tumor to be done, you know, potentially before doing radiation therapy. Cementoplasties are different applications. Putting cement in different areas, the sacroplasty would kind of fall under that area. Osteoid osteomas, doing long bone tumors, and doing the RF before that. The RFA, here's the NCCN guideline, just reference some quick slides here. Finally, talking about our interventional strategies, percutaneous vertebroplasty and kyphoplasties, and doing the ablation techniques highlighted down there on the left. I can get you the whole, I have that whole set available for you. We are absolutely on like page 39 of 42. Here, this was a reasonable study by Ancala, which actually came out in 2015, I believe, or maybe it was at the end of 2014. It was retrospective, 5 centers, and they looked at the use of people with tumors, people with posterior tumors. This was looking at potentially a different tool that uses radiofrequency with a high thermal heat index, but trying to avoid getting, they have a mechanism, I'm not going to use a trade name here, but they have a mechanism to try to monitor the temperature so that it doesn't cause a cord injury. This is that device. I've used it a few times. We haven't found in my centers, we have not found much interest from our oncology colleagues, and so I don't see these patients. But you can ablate the tumor and then backfill it with cement. You can do that and then send the patient to radiation. This is an interesting scenario. This was presented, I think, the next year, and there is the lower levels got the RFA, and then they had radiation therapy, and then above they had the radiation therapy only instead of, the tumor-directed destruction with the radiofrequency. And that was 6 months later. You see the upper levels that patients having erosion into the canal. So the ideas are there. The study numbers are low. The study numbers have been done wisely, I think, and they do show good evidence for tumor ablation before augmentation. There's evidence out there. Getting the oncologist to want our help, I think, is a regionalized area, but there's good information to arm yourselves if you want to go down that pathway. We have different tools, and these different tools are a lot about cavity creation. They're a lot about the vertebroplasty, or the augmentation part of it. Peak grafts, there's a jack, which I have a slide in here. I have a routine wall anchor that you can get at Home Depot. Looks exactly like it. It's the same type of thing. Stents and balloons. So we'll go through some of these. Here's the jack right there in the middle, and the idea is you stick that in through a cannula, and then you have a reverse tool that goes in, and you twist it, and it jacks, and it pulls things up. To my knowledge, that's not yet available in the U.S. The same thing with the stent down here. The stent works in a similar fashion. You put the stent in, and then you crank it back one way, and it collapses and creates this augmentation cavity to contain your cement, possibly provide height restoration, like the balloon. Up there, the top one is a device called Kiva. That does have FDA approval. It's available in the United States now. It's a coiled nitinol tool that goes in, and then you take this peak graft and you put it in on top of it. It was actually FDA approved, although I'm not sure about how that meets with payers for traumatic fractures. So that is what's interesting about that is that it's the only device approach so far that I'm aware of that has indications for acute compression fractures. This is just a summary slide that compares all of them, looking at when you might use them. Different tools for different areas potentially. Not any distinct studies that are going to tell us that one is better than another, unfortunately. So you have to take this all in and incorporate it. If you are very good at using one tool, that might be better than being able to use every different tool for multiple different versions. Because ultimately we're treating this fracture, and again, I would like to propose that you got to remember that this fracture is just an event in a spectrum of care for this patient, and if you don't help take care of the broader picture, they'll be, they could be that guy on the front end that had 17 plasties done, and I don't want to be the guy that did that. This was the peak graph. This was a randomized controlled study that they did and showing benefits. This was from this was as far back as 2013, but it didn't get approval in the United States until 2015. Just some more pictures of the same type of tools. This down here is another stent, not currently available, but it goes in and then you stick a balloon inside of it and the balloon opens up the stent, rather than the one that I showed on the top right that uses a reversed tool to cause it to compress.
Does that just create cavity, or do you actually leave the stent in there?
You leave the stent in.
Okay.
Yeah. So those are all tools and things that you would leave in place. The idea behind this is to limit or minimize the amount of extravasation of cement. Now, other ways of doing that and providing. Oh, this little guy up here got pulled from the market. Gosh, I can't remember. That came around back in 2009 or 2010. These little injectable wafers, and it's called Stacks, S-T-A-X-X, maybe with 2 X's. And my analogy was the shims, that you buy from the hardware store, where you put in one and you inject it, and it's supposed to cause it to go up. But they had some significant complications that occurred, and that was pulled. Here's another little tool. Again, it's like a jack with a balloon. We've got what I do think is useful and neat, and almost every company has some variant form of this, is an articulated delivery mechanism or an articulated osteotome, so that you can create a cavity without using, say, a balloon to cause compression and just crushing all of this potentially viable bone. You can create channels, you can create sort of a star matrix. That's what I like to do. I like to use the delivery tool. I like to look at the MRI or the CT scan, see where the primary portion of the fracture is at, and try to make sure that I'm filling that void. I try to minimize destruction of the native bone that doesn't appear to be damaged. We have different different materials. Some of these, the second to last one, the strontium hydroxyapatite, has been around since 2004. It hasn't really gained traction. We have different things: calcium phosphate cements, silicone polymers, an RF activated cement, which is actively available, and it's kind of a pain to use. The strontium hydroxyapatite, which is not widely available, and then there's some new studies with a recombinant human NEL1 that I came across, which has been done in sheep. All of these are looking at trying to find ways for limiting side effects of cement extravasation, thicker cement, or looking at cements that will resorb over time. Technical considerations, and there were a couple neat things. Again, these aren't tremendous articles, but a couple neat tools that were thrown out there. One of them was an endoscopic resection of some cement that extravasated into the canal. So rather than doing a big open surgery, they went in with some scopes, rigid scopes, and took them out. Endovascular retrieval of a cement fragment in the pulmonary artery was pretty interesting. And we're getting there. And then this reverse Thomas position, which seems to make some sense. The reverse Thomas position to help stretch out the front and try to reduce the fracture dynamically, and then proceed from there. This was done over in Ireland, that they showed that they took fractures at a median fracture heights of 65%. By putting them in this position, they changed it to 78%. Then when they put the balloons in, they got it back to 82%. So it makes sense, something that you might not think about unless you had seen it in a presentation or taking the time to filter through all the data. The take-home message, these are the take-home messages, and these are just a reiteration of things that I've talked about. This is my algorithm, and this is potentially a good tool. This is what I've been able to filter out of the data over the years and making some modifications. But basically, most patients with acute fractures, unless they can't tolerate anything to help with their pain, my first thoughts are to treat them with a little bit of pain medicine. Even if these patients are in the hospital, oftentimes they aren't getting the tools that we know a little bit better than the internists. Key times, I think, are the 2 to 3 day window, the 2 week window, and then sort of the 6 week window. I really find that a vast majority of my patients in 2 to 3 days with a little bit of pain medicine, with the expectation that you're going to taper them off over the next couple of weeks, a lot of them do very well, and we never end up doing an augmentation. 2 weeks, I see them back, we get some lateral films, we identify whether or not there's been any advancement of the fracture. Again, typically not. Usually their pain's better. If it's not, then we have a discussion about where they are with their functionality. Are they making progress? How much is their pain improved? And we're really guiding a lot of this on clinical feedback from the patient. Additionally, a lot of this is back-fed by our insurances, or our insurance carriers, because our insurance carriers will almost never support immediate augmentation for an atraumatic fracture. Some of them say you gotta wait 12 weeks, they've rebutted it. 6 weeks is kind of the average between Aetna and Blue Cross and Cigna. I used to have some slides that I've taken out, but I can get you all of the policies that I've got slides on as well. Summary, again, we've been through this before. I think you guys want to have a break. The best thing I can tell you is take as much information as you can. Listen to your patients clinically. Just because somebody on a report says there's a fracture, just because somebody says, oh, they might be a candidate for augmentation, doesn't mean it's necessarily the best thing to do. And ultimately, although the risks of infection and cement extravasation that's symptomatic is on the order of about 1 in 200, it's 1 in 200. That means every 200 you're going to expect that you're going to have a symptomatic problem. And as we learn in medical school, and as you say when you do your oath, first thought is do no harm. Don't cause problems, don't cause accidents.